So here I am, Dr. Blanche Grube with Dr. Grieco, and we're having an informal discussion here talking about something called occlusal splints. Right, Dr. Derek? We get a lot of patients that complain of TMJ problems. I always find it amusing when the patients say, I have TMJ. And I say, yes, I do too. I have two of them, one on this side and one on this side. TMJ stands for temporal mandibular joint. So if you say, I have TMJ, well, yeah, of course you do. You've got two of them, one here and one here. And we kind of joke around, but I understand that the patients mean that they have a TMJ problem or basically temporal mandibular joint dysfunction.
Right.
So this is our third partner here, and his name is George. Say hello, George. Hello. George has also TMJ. He has a temporal mandibular joint right here, and he has a temporal mandibular joint right here. And if George, it looks to me like, when I look at George's mouth, it looks to me like he has done a lot of fruit and vegetable chewing in his day, and a lot of his back teeth have worn down. And that was exactly God's intention when he gave him these teeth. So George has done a lot of chewing in his time. And if you look carefully, when George opens his mouth and closes his mouth, the temporal mandibular joint, which is in the back here, rotates. It's kind of like a hinge over here, okay? See the hinge? This is the hinge, and you can see it rotates as he opens and closes his mouth. When George wears down his teeth, his lower jaw closes up higher, pushing the temporal mandibular joint back further and putting a lot of pressure on this joint. And so that's why some people have popping and clicking when they open their mouth. They even get headaches from it. And so very often the cure is to put something called an occlusal splint or a piece of plastic on the lower teeth in George's mouth, so that when he closes, he would only close that much. And most of the time George would wear this when he's sleeping at night so that the joint gets a chance to heal. Well, there are some dentists that like to make occlusal splints and place them on the top. And I'm very much against that, because if you take a look, isn't this nice that we can actually turn George inside out and look at the hole at the base of his skull. This is called the foramen ovale. And when George's head is in an upright position, the foramen ovale is where the spinal cord sits, the top of the spinal cord. And so he's like this, and the spinal cord comes out into this area, and the spinal cord pumps up cerebral spinal fluid. It is a fluid that is full of protein and nutrition, and that gets pumped up from the bottom of the spine all the way up, like it was traveling up an elevator. And when the cerebral spinal fluid gets up to the top here, the last section of the spinal cord goes like this, squeezes, and the cerebral spinal fluid goes into the foramen ovale. And then you see all of these bones, all these sutures. The sutures of the head all expand. Now I'm exaggerating the motions, calling it flexion like this, and contraction, flexion and contraction. I'm exaggerating the motion so that you can see it, but the motion does exist. And the bones of the head do flex out, allowing room for the cerebral spinal fluid, and then as they contract back, that cerebral spinal fluid gets pushed into the brain, feeding the brain. So if a dentist was to put an appliance, an occlusal splint, on the top of George's mouth, he would lock the bones on the right and the left side of George's head. Well, take a look. This bone, the lower jaw, is one bone. It is one continuous bone from here all the way across to the other side. Now, I'm going to disconnect George's lower jawbone. So you can now take a look at George's upper bones. If you can see, this is called the maxilla, or the upper jaw, and it's actually made up of a right side and a left side, and there's a huge suture that goes right down the middle. If I was to lock the bones of George's upper head by putting an appliance that would lock his teeth in, then when the cerebral spinal fluid gets pumped in and the bones want to expand and contract, they can't do that because these bones are stuck. If these two bones are stuck, well, then the sphenoid bones that those two go to are going to also be stuck. Then the parietal bones that those go to will also be stuck. The frontal bone is a single bone, but it's not going to have much movement itself because these two bones cannot move. And there's actually 6 bones. There's actually a little one here, middle one, and then the back one. So you get the premaxilla, the maxilla, and the posterior maxilla. All 6 of these bones together make what we call the maxilla. And again, I can't emphasize this enough. If you're to make a splint that goes on the top, you're going to lock the bones of the head, and the cerebral spinal fluid cannot cause the skull to expand and to contract. The same is true for partial dentures that are made that have metal in them and have hooks that snap in place here and hold the jaw real tight. They also keep the cerebral spinal fluid from pumping up. And the same is also true of bridges. Some dentists, if you're missing a front tooth, they'll put a bridge from here to here and lock the bones of the head. Yeah. So it's real important that they not do that.
What do we do, Dr. Blanche? This is a dilemma with kids with braces.
It is a dilemma with kids.
Is it the situation where should they have the wire removed and adjusted periodically, or?
Well, the wires in orthodontics are not that tight.
Okay.
The teeth are moving. Thank God. Otherwise, the teeth wouldn't move to begin with. They're not just locked in place. Unfortunately, it is a problem. They do move and put pressure on the bones of the head, but there's still some flexibility there.
Okay.
And when we eat, the bones, the teeth are kind of like a joint, kind of like a bone to bone joint, but it's a tooth to bone joint. And when we chew and we eat, our teeth move in every different direction. And even if you have braces on, those teeth still move. And so that's a good thing. But I do get concerned when the orthodontics is finished and they put an appliance in to hold the space, right, or a retainer.
And they bond a retainer behind the teeth.
That's right. That's a different story. If they're bonding retainers behind the front teeth, then they're going to lock those teeth in place, and that's not a good idea. So the bones of the head do move, and they flex all of the time. There are over 200 bones. Wow, it's a lot of bones. And they're all connected to each other, and they all do move. I'm very often asked, well, what about thumb suckers? Well, thumb suckers are very interesting people. Of course I'm saying that. I was a thumb sucker. Matter of fact, my father tried to get me to stop sucking my thumb by playing a subliminal album between my sister's bed and mine. He was way ahead of his time, my father. So he would play this album that would try to encourage me to stop sucking my thumb. It didn't work, by the way. I continued to suck my thumb, and I found it very interesting years later when I became a dentist to find out that thumb suckers put their thumb right here in the palate. Well, attached to the maxilla bone, I don't know if you can see it inside the nose, is something called the vomer bone. The vomer bone runs, you can actually see it in the nose here, the vomer bone runs perpendicular to the maxilla. So the maxilla runs this way, the vomer bone runs this way. And when a thumb sucker sucks their thumb, they're pumping the vomer bone up, and that stimulates the floor of the brain. And so the thumb suckers tend to push more cerebral spinal fluid up into the brain, and thumb suckers are 10 to 20% higher IQ than non-thumb suckers.
Wow. Because
they're constantly pumping, they're constantly feeding the brain. So when I see a thumb sucker, right on, kid, keep doing it, because we can always fix the teeth later.
Right.
We've got Invisalign, we've got all kinds of great things to straighten out the teeth if you become too bucktooth. But thumb sucking is a great thing. It's a wonderful way to stimulate the brain and give the child security too.
That's interesting.
Yeah, very, very interesting. I personally would rather see a child, especially an infant, sucking on their own thumb than sucking on a piece of plastic.
Right.
The plastic gets broken down by the acid that's in our saliva. And so then the infant child is absorbing plastic. The human body doesn't know what to do with plastic. Plastic becomes us. Literally becomes us. We cannot metabolize plastic. I've seen slides of electron microscopy slides of muscle fibers with pieces of plastic in between them. We do not metabolize plastic. Our body does not know what to do with it. And so, what would you rather have your child sucking on, a pacifier or their own thumb?
Absolutely, their own
right?
thumb. Right,
their own thumb.
Right.
And then try to gradually, as the kid gets more secure, give them a blankie, give them whatever, get them to the point where they're ready. When they're ready to let go of the thumb, they will. Okay, so that's my little talk on thumb sucking. And George, I think, was a thumb sucker because he's got a very high palate.
Yeah.
And he's a very intelligent fellow. We have some very good conversations. So I'm sure George was a thumb sucker when he was younger. Good night.